Good morning, everyone, and thanks for coming along to this session. Ashley and Marcia have brought to you some facts and some achievements. I'm going to bring a little bit of philosophizing about why we're still where we are and why we still need quality improvement at a very, very broad level to improve the way we use intravenous fluid therapy. So we're always living in a culture of continuous improvement, and we're driven by a number of things. We're driven by wanting to reduce harm, improve our clinical outcomes, improve patient experience, and, as Marcia has demonstrated, reducing waste. And reducing waste is a really valid motivator for quality improvement if the resources that you mobilize can then be put back into improving quality, improving patient care. The title, What's the Harm, that Ashley used today came from a conversation that I had with a surgeon who I was trying to physically restrain from giving more fluid when the urine output wasn't quite what they wanted it to be. And they asked the question, well, what's the harm? Let's just give some more fluid. And we had a conversation about that, during which they didn't persuade me that there was any physiological basis to doing what they wanted to do. And Ashley's described in a lot of detail what the harm is, and we can boil it down, I think, to too much fluid and wrong fluid. Some beautiful slides there showing bags of saline followed by GTN and furosemide. It really hammers the point home. Marcia has shown how, through a lot of dedication, a lot of hard work, you can get people to comply with NICE guidance. And NICE Clinical Guideline 174 provides a huge amount of really, really sensible advice. But yet, we've really only got Marcia's hospital where this is being followed well, and she's doing some spectacular work rolling that out into her region and the rest of Scotland. And it's humbling to see how somebody can make such a great change. And in many ways renders a lot of what I've got to say slightly redundant, because she's shown it can be done. But as I say, we are in a position where not enough people are using fluids safely, and there's a lot of reasons underlying all of that. And it becomes a quality improvement project because we have got a patient safety issue. If we've got avoidable harm caused by prescribers, it's a patient safety issue. And we then have a quality improvement project that needs to be done at a national scale. This is a pretty dry definition of what quality means, the degree to which healthcare services for individuals and populations, blah, blah, blah. It's really, really difficult to bring that into the patient and avoidance of harm for whatever intervention you want to do. Back in 2008, we're all introducing our quality improvement heroes today. Donabedian and Darzi shone a light on quality from the patient's perspective. It's okay, it's still up there. Sorry, we're just having a few problems with what's in front of me, but the slides are up there, we're fine. And Lord Darzi shared with us the three domains of safety, effectiveness, and experience. From a safety perspective, can we map IV fluid therapy to safety? Emphatically, yes. We've demonstrated that. Clinical effectiveness, less so. We've got fluid studies that show benefits to one kind of fluid over another, but we've never really had that killer RCT that says, here's how you do fluid management. So it's difficult to really show that we can improve clinical outcomes with a particular way of doing things. Patient experience is a much more difficult one. I did read once somewhere that if you give 2 liters of saline to somebody during day case surgery, then they don't feel as well as when they get 2 liters of Hartmann's, but of course The big question is, why were they giving 2 litres of anything during day case surgery? If we want a nationally understood improvement project, we're going to have to measure what we're doing. We're going to have to measure quality. Now, I'm guilty of watching too much football, and I like to snigger sometimes at the use of the word quality by football pundits and football commentators. That ball that went in there just needed a bit more quality, or that was a quality strike. It's a shame that it was just wide. Things like that muddy the waters with quality, but also we get a load of really, really useful stats. We know when someone's won. The scoreline tells us that. An easy to measure quality marker. But sometimes a team might win 1-0, but they've been all over the other team. And we have this expected goals metric, and it's a really, really good way of describing quality when the outcome is not so easy to measure. And that makes things good for the football pundits, doesn't help us so much in healthcare. If I were to approach my medical director, and I have imagined this conversation, if I were to approach my medical director and say, Phil, I want to, he's called Phil, Phil, I want to improve quality in fluid prescribing in my hospital, he's going to say, okay, so what's the problem? I'll say, well, there's harm. And he'll say, what's success going to look like? And I'll say, well, we'll just do it better. You know, it needs to be better quality, football pundit style. And he's going to send me away, and I'm going to need to come up with something to measure that will show that we've been successful. So, continuing the theme of introducing our quality heroes, some of you may have heard of this chap, Donabedian, who speaks about, who gave us the tools to measure quality, particularly where the outcome is not easy to measure. And he gave us a schema of structure, process, and outcome, which is used to this day. It's been in use for decades. NICE still uses that schema, and all quality improvers understand this and know it. When our quality marker of an outcome is not easy to measure, we can still make improvements, and Marcia has shown that by setting in place a structure and a process. And if we understand that we can still measure process, we can still measure structure, then we can still improve things for our patients. Quality in intensive care, well, we get these metrics. Very few of them relate to patient outcomes. If we look at risk-adjusted mortality, unit-acquired infections in blood, these are the only things that they send back to us after we submit all of that data that relate to patient outcomes. The rest of these things describe the structure in which we operate, and that structure is important. That's the structure in which quality thrives. If we have got lots of out-of-hours discharges, then we've demonstrated an environment in which quality can't thrive because we've got a problem with our patient flow. For example, what else do we measure in ICU? All kinds of things that are easy to measure. We can measure pressure ulcer incidents, we can count them. We can measure VAP bundle compliance because we can put out a VAP bundle and tell everyone to do it and measure the process. So we can measure processes, we can measure outcomes, we can put structures in place, and that works well for a lot of things, but it's really quite challenging with IV fluid prescribing. So the big QI project, what needs to change? What outcomes do we want? We've established we've got a patient safety issue. Some patients are getting too much fluid and it's causing harm. Some patients are getting too much salt, it's causing harm. We're seeing edema, both on ultrasound, we can see it on our ultrasound of the chest, we can see those scans that Ashley showed in the first talk where there's free fluid everywhere or interstitial fluid everywhere. And as Marcia has shown, we can also reduce waste, and that is a worthy outcome because it means that we can put resources back into our patient care. So that is a little brief tour of what motivates quality improvement and what helps us to measure it. What are we up against? Why do we keep giving too much fluid? Well, we're still teaching 19th century physiology in medical school, sometimes in our Royal College curriculum, and we've got people teaching people and passing down this old information generationally. We've spoken about who prescribes fluid, and who they're accountable to. And they might have very different ideas about what fluid prescription should look like. Fluid boluses, fluid maintenance, it varies widely depending on which consultant you ask. Whether they're an intensivist or a surgeon, people might have very different ideas, and they probably shouldn't have. There should be some unified ideas here. There are traditional fluid titration targets. You've all seen somebody give a bag of fluid, the lactate comes down, and we're going to keep giving fluid until the lactate comes down to normal. Likewise, urine output with that conversation that I described with our surgeon at the beginning of this talk. And this idea that you have to swell to get well and then get deresuscitated. Ashley's already covered that, but it's a very clear evidence that you've harmed a patient if you've actually caused avoidable edema. So it's difficult to understand why when we know all of these things, why are we still doing it? So what mistakes do we make? We keep giving fluid because the lactate's high, and actually titration to lactate is something that's appeared in international guidelines in the past. We sometimes give too much fluid because patients are transiently fluid responsive, and our cardiac output monitor will say that they need more fluid because the stroke volume's come back down again, or the stroke volume variation's gone back up again, and it's telling us to give more fluids unless we apply what we know about the physiology. All of these things are well established, they're ingrained behaviors, and it takes a lot to break that dogma. We've also got ingrained behaviors regarding fluid choice, and this has been mentioned in all three talks now. I can't go on about choosing the wrong fluid. We know what's the right fluid. We know which fluids to give. We just need to spread this word and find ways of implementing it on a very, very large scale. Standing talking to an auditorium is great, but we'd really like to engage the entire NHS in something like this. And we've also got confirmation bias. As I say, we've seen lactate fall every time we've given fluids, but actually carrying on chasing that is a very common practice, and when lactate falls at the same time that you're giving 9 litres of fluid, you might actually start thinking that 9 litres of fluid is the right thing to do, especially if you didn't have an ICU bed and you were trying not to give them some noradrenaline. I think that I've seen that practice quite a lot. I think there's room for a little bit more. We might just be able to keep them out of ICU with another litre of fluid. And we've got years and years of people thinking that if I give albumin and furosemide together, we'll mobilize all that edema, the edema that we shouldn't have allowed to happen in the first place. And of course, we see the edema go away. It was probably the furosemide, not the albumin. And if you listen to one of Ashley's longer talks, he'll explain exactly why albumin cannot help in this situation. The science is very solid. And finally, we're up against cognitive dissonance. Sometimes we know we shouldn't be giving any more fluid, but we just do because, well, I can't think of anything else to do. And I had that conversation with a colleague a few weeks ago who told me that she'd given more fluid despite knowing it wouldn't work, but what else could she do? So how can we measure success? And this is the point where I want you to start thinking about what that measurable is. We can't really use length of stay, organ dysfunction, mortality, those big hitters in measuring quality. We need to think of another outcome measure. These aren't going to work. And that measurable outcome would like to be related to the harm that we're causing. That edema is the thing that we are associating with harm. Edema is avoidable harm. Edema is the patient safety issue in so many of these cases. But it's not very easy to quantify edema, and I can't see a quality improvement project that's going to impress my medical director because I can't really measure edema. Congestion, which we've spoken about today. I'd love to do daily Vexus ward rounds on every patient and do a venous excess ultrasound assessment and prove that we've reduced congestion. It's not going to happen. It's not something that we can measure on a large scale. What we do measure on a large scale is weight and fluid balance. But I know that in my intensive care unit, only half of my beds actually weigh the patient. The other half are a little bit older and don't. Fluid balance, well, I've seen patients with a 30-litre cumulative fluid balance accumulated over a 25-day admission. I've no idea what that means, so it's very difficult to measure any of these things as suitable patient-centered outcome measures. So we'll bring back the heroes to see if they can help us, and really, it means for now, we're going to have to concentrate on that structure, do what Marcia has done, but we need to do this on a very, very wide basis. We need to do it across the country. That structure, the environment in which quality will thrive, is based around education and leadership. That leadership structure has already been described to some extent in the NICE guidance of having an IV fluid lead. Actually, it turns out you can get an IV fluid team and make a big difference. We need good quality clinical policy. Not just NICE guidance, but guidance that works for your intensive care unit and for your hospital, for your acute hospital. And then we need to measure that process. And this is really helpful and a good enough measure for most scenarios to show that we're making a difference. If we are applying the processes in the right environment, we will be undoubtedly reducing harm. It's just very difficult to measure that reduction in harm. So the outcome is the confounding factor. That's the gnarly bit here that we're going to struggle to get through. And it's the point now that I want you to start thinking about and bombarding our moderator with what you think the outcome measure could be. What do you measure in your intensive care unit that might help? The structure in your intensive care unit is going to have to be leadership and education. I'd like the National Education Programme just to be Ashley's talk. I think that covers it absolutely perfectly. In your hospital, a trust-wide IV fluid lead. Can we have a quick show of hands? How many people here know the name of or even know the existence of an IV fluid lead in their trust? I'm getting about 4 or 5, maybe 6 hands up there. So this guidance was introduced in 2013, and it's just not making that dent, not yet. So in our healthcare system, again, we've got to build that structure. The medical schools are not teaching fluids the way that we think they should now be taught. The Royal College curriculum for anaesthesia doesn't include the revised thinking about the Starling equation and the glycocalyx. These are things that probably need to be in there to help the future experts understand rational fluid prescribing. And our policy needs to be guided by any new understanding, any new evidence that emerges in the literature. Process measurement is a bit more straightforward. We need to implement policy, we need to measure adherence to that policy. I find myself thinking out loud, do we need a little bit more policy on indications for fluid boluses, fluid challenges? Do we need to nudge people to justify why they're doing it so they don't rewind and start making all of those old mistakes that we see people making all the time? And the outcome? Well, in CG 174, NICE doesn't even suggest an outcome. And I think that we probably will need an outcome at some point if we're going to make progress in nationally improving quality fluid prescribing. The outcome, I think, should be based on edema risk. And I've already discussed the problems with fluid balance and daily weight. I wonder, again, whether a pre-ICU 24-hour resuscitation volume will tell us a lot about what's happened before the patient comes to intensive care. But it feels too difficult. It feels complex. We might just have to settle with structure and process with no outcome. So the manifesto then for education is to make sure that everybody understands beyond euvolemia there's harm. Congestion causes organ dysfunction. Fluid overload is an avoidable adverse outcome. And this is where I think we highlight this is a patient safety issue. This needs to drive quality improvement in the same way that we've had national drivers for things like venous thromboembolism. We now all have our processes measured and we comply with those as well as we can, and we are undoubtedly avoiding harm, saving lives. We need to make sure that everybody knows that we're still giving too much sodium despite everything we know. I've mentioned the education should probably include a little bit for the experts regarding the revised Starling equation and the glycocalyx. And I think we need to get a strong message out there that the lack of or the transient response to fluids should drive us to bring our patients to intensive care sooner, give pressor support sooner. If we get all of these things into the education program, we'll have dealt with the myths. The IV fluid leads, as I say, something that was recommended in 2013. We're nearly 10 years past that now, and nobody's really doing it. I think we need a network of IV fluid leads. I think we need to all agree on the message, agree on the role, agree on what an IV fluid policy maker and implementer should look like in every single hospital. We've seen a bit about formulary management from Marcia. We've seen how you can train fluid leads to achieve a consistency of message across a few hospitals, and we need more and more of that. What will success look like for this QI project? It would be the existence of the correct structure. It would be an embedded education program where everybody's teaching the same truths. And maybe one day we can all be measured and complying with all of the processes that we've set up and have an agreed outcome measure. And that would be perfect IV fluid management, in my opinion. Thank you very much.
Thank you. So unfortunately, Ashley's had to leave us because he had to catch a flight back home. So we just have two of our panel members here. But I would like to open this session now up to the audience. I think we've heard some amazing talks about reminders of the physiology, a fantastic quality improvement initiative that's been sustained over time, and then the issues that we are all facing in our organisations, and those barriers to change. And I think when you were presenting the barriers, Andy, I was thinking, one of the problems is we're not very good at doing nothing. We always want to do something, and so we all push each other. Well, we've got to do something, and we're very bad at let's just ride it out a little bit. So I think that's...
Don't just stand there and do something. It goes around the other way as well. Don't just do something. Stand there.
Exactly. So I can't see any immediate people asking questions. What do we have on the...
A few questions here. To Marcia, did you find with the introduction of fluid nurses did you find that it relieved referrals input needed for ICU and critical care outreach?
So I didn't hear the last.
Oh, sorry.
Bit.
So, with the introduction of fluid nurses, did you find that you had less referrals for ICU and for the outreach nurses?
The fluid nurse has not been so much going around making sure everybody gets the right amount of fluid. She's more an education role. And she does lots of other things now as well related to that. But what we haven't measured how many referrals we had just from overload, but it's the impression from my colleagues is that our patients are not coming hugely overloaded now like they were, and also the surgeons have said that they're very happy that their patients aren't getting really edematous and very overloaded, and it's better for their anastomoses, but we haven't actually got measurements of that.
And do you feel that admission to critical care due to over-aggressive or inappropriate fluid prescribing should be a never event?
Sorry, I'm having trouble hearing you. Can you speak a bit slower?
So do you feel that the admission to critical care due to over-aggressive or inappropriate fluid prescribing should be a never event?
Yes, I think if it's just due to that, it definitely should be a never event. I mean, I can't think of the last time we've had somebody just because of that. Sometimes it's an element, but mostly it's not a problem too much with us, I have to say.
I can certainly think of episodes that should have been a never event. Whether all episodes, it's going to be difficult to tease out which ICU admissions were solely the result of overzealous fluid administration. But I can think of one where a 37-kilo patient presented for surgery, and for 10 days they chased the urine output, and she arrived on ICU weighing 52 kilos.
Wow.
So that should have been a never event.
So do you feel we should datex things like that?
Yeah, I mean, these are episodes of avoidable harm. And put in that context, and I'm really trying to frame this now not as a physiological teaching, but because we've been having conferences where people talk about fluid management for years now. But I think what we should be framing this as is a patient safety issue if we're causing harm. And where we suspect harm has been caused, yes, I think that it would be suitable to make that an incident report of some kind.
Yeah, the NICE guidelines actually have a section about reporting complications, and one is fluid overload, one is fluid underload, and then there's hyponatremia, hyperkalemia, hypokalemia, and it says report all of these. Now, that's never going to happen. Most of our datex reports are about somebody putting the wrong fluid that wasn't prescribed up or the wrong rate, but it would be great if we could get more information from the wards about the clinical stuff that's going wrong as well.
And I've got a question here. What is the best way to differentiate between hypovolemia and vasodilation?
That's a question for Ashley, isn't it? So it actually is quite straightforward in terms of using the basics. We have some preconceived ideas that a septic patient, when they arrive in hospital, will be hypovolemic, and our guidance tells us that we should be giving fluids to septic patients. But as Ashley said, the reason why people are grossly hypovolemic is either GI losses or hemorrhage. And if your septic patient in front of you has had neither of those, then the scope for severe hypovolemia is quite low. Yes, they may have been poorly and not drinking enough, but actually they are unlikely to be grossly hypovolemic. And that first bag of fluid isn't the one that will do any harm. It's okay to give that first bag of fluid. It's the following 9 that we all too often see that we need to tackle. I often wonder why they stop at a certain point, why at some point we think, well, I'm going to stop at 8 there. I think 7 wasn't quite enough, but 8 is enough. So I think once we've given a small amount of fluid to our septic patient, we can assume that the hypotension we're seeing is due to vasodilatation. And of course, that's got tremendous consequences for critical care capacity, because we spend a lot of time giving fluids to these patients so they don't need to come to critical care. And if they actually need pressors, we're going to have to bring a lot more patients to critical care. That's a big step to take for an under-resourced, understaffed system that's been chronically short of capacity.
So can I make a comment on that? We have a thing in our guideline, and we teach induction. If you're having to give more than 2 litres and the patient's still hypotensive, please contact critical care. And also we've introduced peripheral noradrenaline, so it can be started in A&E. It can be given in medical and surgical high dependency. We used to use metaraminol infusions. We still do post-op, but it's less effective in septic vasodilatation, I think. So we now use peripheral noradrenaline. Seems to be safe, but only in A&E or a critical care area. But we try and avoid people just getting lots of fluid to stop them getting into critical care. If an elderly person just needs a bit of vasopressor, then let's bring them to HDU. We may not put them in ICU, but we would still support them and keep their blood pressure up.
And that's following NICE guidance, exactly as they said. If you reach 2 litres, seek expert advice. They don't describe what expert advice is, and I think a lot of my colleagues will still say, give them another bag. And I think that's what we have, that's our educational challenge at the moment, and it starts with us in critical care, because we are seen as the experts in fluid management.
I was going to ask you, Marcia, you demonstrated like a lot of education in your program. Was the education, and to a lot of different people, but did you do it as interprofessional education, getting the teams together, or was it siloed into let's teach the doctors, let's teach the nurses, let's teach the pharmacists?
We don't always teach them together, but we try and teach all the different
Because I think this is a really important area for interprofessional education, because you have the nurses pestering the doctors and vice versa, and I think there is a problem in that, right? And if you got everybody in the room understanding this, I think that there would be some changes to be made.
I think our main issue with nursing teaching is that they're not given time, and Emily goes around the wards trying to get them together to teach them, and they don't have time. So that's a big problem. Yeah, it's really bad.
Question, please.
Question at the back there? Absolutely.
Hi there. Thank you very much for the talk. So very informative. A local intervention that I've seen recently on antimicrobials is that we've got drug charts that force you to re-prescribe your antimicrobials after 72 hours. I wonder if a similar intervention, given that the danger point isn't on admission to ED, the danger point is a couple of days later, I wonder if a similar kind of intervention with fluids might be a sensible thing to try and combat that letting things.
So our fluid chart has, you probably couldn't see it, but it's split into maintenance at the bottom and replacement resuscitation. And each bag, it's just for 24 hours on the fluid chart. And after each bag, it says stop, continue, or review. And you're meant to have one of those. So I suppose when you've got electronic prescribing, it might be a bit easier to enforce some kind of change. But we do try and prompt people to think very hard before they're putting another bag up.
I am going to have to bring our session to a close. I'm sorry, the big sign is flashing over there. So I would like to take the opportunity to thank our brilliant speakers. And if anybody else has got other questions, please come to the stage and you can ask people individually if they've got time to remain. Thank you.